All right, today we're tackling a fascinating topic in pregnancy, placenta previa. Now, imagine this. The very organ that's supposed to be a baby's lifeline, what if its location actually turns it into the biggest roadblock for a safe delivery? It's a real paradox. So, what happens when a baby's lifeline is blocking the only exit? I mean, that's the central puzzle here, right? The placenta, this amazing organ that's feeding the baby, providing all the oxygen and nutrients. Well, in this case, it's set up camp right over the exit door. And that, as you can imagine, creates a really tricky situation that needs some serious, careful planning. Okay, so here's how we're going to break it all down. First, we'll get into what exactly this condition is. Then we'll talk about who's most at risk. After that, we'll cover the classic signs, how doctors manage it, and finally, the big moment, delivery and what to expect. All right, let's jump right in. First up, what is placenta previa? We've got to start with the basics to really get a handle on the challenges it presents. Okay, here's the deal in a nutshell. The placenta, instead of attaching way up high in the uterus, where it's supposed to be, it implants down low. Sometimes it even ends up partially or completely covering the cervix. And in pregnancy, location is everything. It's this specific misplacement that makes it a major, and I mean major, cause of bleeding after that 28-week mark. Think of it this way. Normally, the placenta is chilling up in the penthouse suite of the uterus, totally out of the way of the exit. But with placenta previa, it's hanging out in the lobby, right by the front door. The real problem starts late in pregnancy when the lower part of the uterus starts to stretch and get ready for birth. The placenta isn't elastic. It can't stretch along with the uterine wall. So what happens? It starts to pull away, and that's when you get bleeding. And get this, it's not a one-size-fits-all condition. Doctors have broken it down into 4 different types. It all depends on just how close the placenta is to the cervical opening, which doctors call the os. You can think of the os as that doorway we talked about. So a type 1 is just kind of near the door, a low-lying situation. But a type 4, that's a total roadblock. The placenta is completely covering the exit, and that means a C-section isn't just an option, it's the only safe way out. So that naturally leads to the next question. Who is most at risk for this? What are the things that make it more likely to happen? Let's dig into that. Well, there are a bunch of factors that can increase the odds. Things like having had several babies before, or a previous C-section, or really any kind of uterine surgery, like a D&C. You know, it kind of makes sense. If there's some scarring up top in the uterus, the placenta might just look for a smoother spot to implant, which could be lower down. Being over 35 or carrying twins or triplets also bumps up the risk. And here's the key to understanding why the bleeding happens. It's really just simple mechanics. So the placenta implants down low, then in late pregnancy, that lower part of the uterus has to stretch and thin out. It's just what it does. But here's the catch. The placenta itself isn't stretchy, it's inelastic. So when the wall it's attached to stretches, the placenta can't keep up. It starts to detach. And that separation tears open blood vessels. And voila, you have bleeding. Okay, so we know what it is and we know the mechanics behind it. But how do you even know you have it? Let's talk about the telltale signs and how it's diagnosed. There is one classic sign that screams placenta previa to doctors. It's this sudden onset of bleeding, but with 2 very specific features. It's painless, and the blood is bright red. That bright red color means it's fresh bleeding. And it can come out of nowhere, completely unprovoked, which is why it's so alarming. So when a patient shows up with that kind of bleeding, there's a huge flashing red light for the medical team. There is one specific examination that is an absolute 100% no-go. And this is it, a critical safety point. A digital vaginal exam is completely off the table. It's so dangerous because you could literally poke the placenta, causing a small bleed to turn into a massive, life-threatening hemorrhage in seconds. It is strictly forbidden until an ultrasound has confirmed the placenta is not in the way. So instead of that dangerous physical exam, how do they confirm it? With something incredibly safe and accurate, an ultrasound. It's the gold standard, no question. The ultrasound gives doctors a crystal clear picture of exactly where that placenta is, with 0 risk to the mom or the baby. All right, so the ultrasound confirms it. Now what? This is where the clinical plan comes in. And really, it boils down to 2 main paths, 2 different strategies for managing the rest of the pregnancy. And the choice between these 2 paths is all about balancing safety and time. On one hand, you have what's called expectant management. This is for when the bleeding is mild and the baby isn't full term yet. The goal here is basically wait and see. Buy the baby as much time as possible to mature, often with bed rest and close monitoring in the hospital. On the other hand, if the bleeding gets really heavy or if the baby is already at or near term, the plan switches to active management. And that means one thing: it's go time. The priority becomes delivering the baby safely right away. And that brings us to the final chapter, delivery and outcomes. This is the home stretch, the most critical part of the journey. So, how is the delivery planned? And what are the potential outcomes for everyone involved? Okay, remember those 4 types we talked about earlier? This is where they become absolutely crucial. Because for types 3 and 4, the partial and complete blockages, a C-section is mandatory. There's just no other safe way to get the baby out. For the lower-lying types, I and 2, a vaginal delivery might be possible, but you can bet it's going to be in a highly controlled setting with extremely close monitoring. Now, it's important to remember that while this is a serious condition, modern medicine has made it very, very manageable. But there are still risks, for sure. For the mom, the biggest concern is always hemorrhage, major blood loss. And for the baby, the main risk is often prematurity, since they might need to be delivered early. The good news is, medical teams are well prepared for all of this. So how does a simple ultrasound transform what could be a huge pregnancy crisis into a totally manageable clinical plan? That really is the heart of the story here. Not so long ago, this diagnosis was filled with uncertainty and, frankly, a lot of danger. But today, that simple, safe ability to just see where the placenta is changes everything. It allows doctors to get ahead of the problem, to make a clear, proactive plan, and to turn a potential emergency into a well-managed journey towards a safe delivery. It's a fantastic example of how technology has totally changed the game in obstetrics.